Good afternoon, everybody.
Good afternoon, Brian.
All right. So I think I'm the last talk before the wrap-up. And as before, I have no conflicts of interest to disclose. I don't work for any pharmaceutical companies, and I'm not here to promote any particular medications. So there is the smoking cycle. The smoking cycle goes something like this. You smoke, and then the nicotine levels quickly go to your brain. The fastest way to get a drug to your brain is to smoke it because it goes into your lung, what's called your pulmonary vasculature, which is blood vessels that feed your lungs, and then those go right into your left ventricle that then goes right into your brain, right? So it's the fastest, it's faster than injecting, it's faster than pretty much any other way of delivering a substance. Fast, goes right to your brain. And nicotine activates dopamine, so you have a pleasure response. But nicotine doesn't last that long in your system. We'll go into the half-life, but it doesn't last that long in your system. And so when your blood levels fall, you have a craving, and you think, I want to smoke, and you begin to feel irritable and restless without it. That's the smoking cycle. So this is, again, same idea. Use, intoxication, saturate receptors, relief from pleasure, drug levels drop, you crave. This is the part where smoking cessation medications can be very helpful, is in, as your nicotine levels drop, giving you some pharmacologic support, some medication support, something that binds to your brain receptors that then keeps you from going back to use, or reduces the chance you're going to go back to use. So that's what I'm going to talk about. But incidentally, the way that clinical trials are structured is everything's controlled, right? Like you have participants come in and they're assessed to have a condition, say tobacco use disorder, and then you see, okay, we're going to give you a patch, and you gum, and you Varenicline, and you Bupropion, and then we're going to give you in sufficient numbers that we get statistically meaningful values, and then we'll compare which one was best. And if we did that, well, here's my question to you. Which form of medication for smoking cessation is best? The classic answer is combination NRT. Classic answer, combination NRT. Followed by Varenicline, which actually, if you look at the confidence intervals, is not statistically different, right? Like, yes, it has an edge, but statistically, they work. They both, and they are solidly better. Combination nicotine replacement therapy, which I'll go over what that is, or Varenicline alone, is classically better than just one thing, like the patch. It's better than like the patch alone. It's better than the gum or the lozenges alone. So that being said, my answer is the best medication for smoking cessation is the one the patient takes. Because the real world does not work like a clinical trial. The real world is not randomized where everything's controlled. The real world is where people have opinions, beliefs, physiology, responses, and we don't always know who's going to respond to which agent. So I don't live in the clinical trial world, and I think much more, how do I link a patient to a treatment that's going to work for them rather than thinking in abstract which treatment works better for this condition. Because I would much rather have somebody on the patch alone than for me to prescribe them Varenicline that they're never going to take. You know what I mean? Like I'd much rather have them just be on the patch. This has already been covered. The reasons the providers tend not to ask about smoking status is too busy and people don't feel like they have expertise in it and it's not a financial incentive to ask and think the tobacco users can or don't want to quit. But providers do have a strong opportunity to ask and act. So 70% of tobacco users want to quit. Without assistance, it's like 5% able to quit. I think that's an annual number. Most tobacco users try to quit on their own, but it's chronic and relapsing condition, so 95% relapse. I think those are annual rates. And then providers that use evidence-based programs can more than double quit rates. So I think every speaker has covered the 5 A's, so I'm not going to belabor the ask, advise, assess, assist, and arrange part. But I do want to point out that smoking is much more prevalent in mental health populations. This is sort of widely known. One of the things we haven't talked about, but in LA County, but also in kind of the world, addiction treatments sits as separate from mental health, right? So there's your physical health, that's primary care. And then there's your mental health, and mental health gets defined as everything that, other than an addiction, right? And tobacco occupies this really odd space because tobacco is not managed by the specialty addiction treatment system, right? We don't have rehabs for tobacco. We don't have detoxes for tobacco. We don't set up a structure around tobacco like we have around alcohol, opiates, amphetamines, cocaine, kind of the rest of substance use disorders. Tobacco is in this kind of like a primary care activity that is treated with the interventions that exist in kind of mental health and in substance use disorder treatment. Okay, so in substance use disorder treatment, we see much, much higher prevalences of smoking in, say, methadone clinics. Some of the highest rates of smoking I've ever seen is when I go to AA meetings or 12-step meetings. I mean, what's there? Coffee and cigarettes. It's coffee and cigarettes. And so we sort of like shrug our shoulders and say, okay, well, all right. So people with high amount of behavioral health burdens like mental health conditions or other substance use disorders smoke. Fair enough. You want to take one thing at a time. I hear this all the time. You want to take one thing at a time. Don't address the smoking, get the depression under control, or don't address the smoking, get the alcohol under control. And I sort of have to remind people that actually smoking has a direct effect on the things that you would use in order to treat people's mental illness. So it has a direct effect on stress and anxiety, which affects your capacity to participate in behavioral health programs at all, and it affects psychotropic medications, specifically through P451A2, which is a enzyme in your liver, and that affects a whole bunch of the antipsychotics that are commonly prescribed to people with schizophrenia, schizoaffective disorder, or bipolar disorder, and many of the antidepressants that we prescribe to people with depression, anxiety, or fibromyalgia, chronic pain. There's a whole list, and I'm not going to, we'd probably spend a whole hour just going through the list, but there's a list actually published out of Australia that is, from my view, the most complete list of interactions between smoking and medication interactions that I've seen. So I'm certainly happy to make this slide available to you, and you can go check out the list. I do think that most people don't think about smoking as like a med interaction, sort of used to in our health record systems checking for interactions between prescribed meds, that we forget that actually nicotine is a big inducer of liver enzyme activity, and so our liver begins to metabolize our meds faster. So one of the things that means is, and I see it all the time, people go into a psychiatric hospital, potentially for a prolonged psychiatric hospitalization. The psychiatrist spends a lot of time getting the meds right. And what happens when people leave the psych hospital? They go smoke, right? And all of a sudden, those meds that were stabilized inpatient when somebody wasn't smoking or had very reduced levels of smoking, all of a sudden, they become psychiatrically decompensated. And part of that could be due to the effect of smoking on the liver metabolism. And conversely, I prescribed a lot, when I used to work in the Department of Mental Health, prescribed a lot of smoking cessation medications, and I ran a smoking group and did a couple other things that got people to reduce or eliminate their smoking. And then all of a sudden, people who were stable on meds for a long time began to show signs of some toxicity, some higher than needed blood levels. And part of that was due to the change in smoking status of the way that it affects their mental health. So I do think that it is important for all clinicians, mental health clinicians, primary care clinicians, to be aware of the pharmacokinetic effects that smoking has on drug metabolism. And we know that most co-occurring smokers, that is people with tobacco use disorder and other mental health conditions, tobacco use disorder is almost never documented in the medical record, probably because it's not a billable diagnosis, especially mental health. So if you don't get paid to do it, like why? I mean, not to be, but that's like probably one of the big drivers for why tobacco use disorder is really rarely documented. And psychiatrists, as practices go, have one of the lowest awareness of quit lines of almost any specialty. Okay, so I think we all know now that there's a California Smokers Helpline and how to access it. So what about this thing of like take one thing at a time? Let's get the depression under control and then we'll treat the tobacco use disorder. So smoking cessation during mental health treatment reduces depression, anxiety, and stress on par with what you see from antidepressant medications, right? So one of the big interventions you can do for somebody that's saying, I'm really distressed, is to support them in a quit attempt. Now, that doesn't mean that somebody who is in the midst of like an active suicidal episode might be ready at that very moment, but part of their recovery includes not relying on cigarettes to manage their stress and anxiety. So does anyone know who this is? Philip Morris. He is an old white guy, that's true. So this is a picture of Bill Wilson. Who's Bill Wilson? Yeah, one of the co-founders of AA. He with Dr. Bob. Now, how did Bill Wilson die? How did Bill Wilson die? People say it's alcoholism. Now, he stopped drinking. He found AA. He stopped drinking. So he did not die of alcoholism. How did he die? Emphysema. He died of emphysema. And so the irony here is here's a person who develops a treatment that is like referred to thousands of times a day here in LA, right? I mean, like people get referred to AA all the time to get their alcohol use under control. And what happens at AA meetings? Smoking and coffee, right? And that will kill you, right? So we think of alcohol as an important, and it is. Addressing alcohol use disorder is a vital issue. But if we forget that tobacco use disorder is just as deadly, it may not kill you as quickly, right? But it's just as deadly overall. And those death certificates don't say tobacco use disorder. They say things like strokes, heart attacks, lung disease. Okay, so this is now the bulk of the presentation, the tobacco use disorder medications. So there are 3 molecules that have been FDA approved for the treatment of tobacco use disorder: nicotine, varenicline, and bupropion. Now, nicotine in a medication for tobacco use disorder has been FDA approved. There's 5 different medications that use that molecule, right? So it's one molecule, but it can be delivered in 5 different ways. Varenicline is the only one we do, it's a pill. And then bupropion has a short-acting version, a medium-acting version, a longer-acting version. So there's 3 different names for the medicines that are used for bupropion, but these are the molecules. So we're going to go through these molecules. I'm prescribing you a patch to help you quit smoking. Please wear it over your mouth. So like I said, which is the best medicine? It's the one the patient takes. Patient preference is paramount, right? Patient preference is paramount rather than saying, aha, you smoke this much or you smoke that way, so you get this medicine. If you're not using a shared decision-making framework, then you're not going to be actually successful at engaging a patient to actually utilize these tools. Clinician familiarity with the medication, contraindications for selected patients, positive patient experiences with a specific agent, knowing what somebody's responded to in the past can help, and knowing what they responded poorly to in the past can help. Knowing both of those things is important. And then patient characteristics around concern around weight gain, history of depression might push me to use a medication more than the other. Okay, I just want to go over how these work really quickly, and then we'll kind of go into them. So I went back a couple slides. So nicotine is the same molecule that's in cigarettes. So you ignite a dried out tobacco leaf, and there's, thousands of molecules that are in there that get, including the polycyclic aromatic hydrocarbons, and that's what causes cancers and inflammation. Nicotine itself is thought to not be directly carcinogenic. Now, it has health effects. Nicotine's not benign. In fact, nothing is perfectly benign. None of these medicines lack side effects. Every medicine has side effects. Nicotine has side effects. The reason that you would give somebody nicotine if they're a smoker is that you can bridge them from having a physiologic nicotine dependence. You can give them nicotine so they can give up that behavior while still satisfying their physiologic need for nicotine, and then taper the nicotine off. That's the idea. So it's the same molecule, but nicotine itself has nowhere near the amount of toxicity and cancer-causing effects of inhaling burnt tobacco leaves. Does that make sense? So that's the idea. Isn't that nicotine is like this great substance that everyone should be on, but that when used for somebody that is smoking, you can use it to get somebody from smoking to not smoking, and then you get them from being physiologically dependent on nicotine to not. So that's the idea behind nicotine. Varenicline, which goes by the trade name Chantix. So I'm going to say the word varenicline, but it's in your head. You can translate that to Chantix. That's what I mean. When I say varenicline, I mean Chantix. That's what I'm talking about. That's the trade name for varenicline. So it is a high-affinity partial agonist at the nicotine acetylcholine receptor. What does that mean? What that means is it binds the receptor tighter than nicotine does, but it only activates the receptor a little bit. So you take it, and you can smoke on it. And I've had patients, they take Varenicline, and they smoke on top of it, and they're like, it doesn't taste the same. It doesn't feel right because the nicotine isn't binding to the nicotine receptor, so it's blocked by Varenicline. So Varenicline blocks nicotine from binding, Chantix blocks nicotine from binding to the receptors, but gives them a little bit of activation. So it's not the same as giving a full nicotine molecule. It tickles the receptors, but it blocks nicotine that you would smoke from binding. Does that make sense? What Chantix does or Varenicline does? Okay. It's so actually it's closer to buprenorphine. It's closer. It's like the Suboxone of smoking, because Suboxone does activate your opioid receptors a little bit. The closest we have there is, unfortunately, so Vivitrol is an opioid antagonist. It's an injectable. We don't have any injectables for smoking cessation yet, but wouldn't it be cool if we did? So Bupropion, I guess, would be the closest because it's metabolized into 3 different metabolites, and I believe, if I'm not mistaken, it's the hydroxybupropion that has antagonistic properties of the nicotine acetylcholine receptor. So what does that mean? That means that it actually has some blocking effects on nicotine. Interestingly, it doesn't, it's what's called a non-competitory antagonist. So it keeps the receptor from working as well as it would have if the nicotine had bound to it. So I think of it as like a modulator of nicotine activity in the nicotine receptors. So all of these molecules affect nicotine. So what's different about the medicines is how they're delivered, right? So a nicotine patch delivers nicotine in a really different way than the gum or the lozenges. And Medi-Cal doesn't pay for these, but the nasal sprays or the inhalers also delivers nicotine in a different way than the patches, the gums, or the lozenges, right? So Varenicline's a pill and Bupropion's a pill, but these are all delivery mechanisms for these molecules into the body. Okay, so the patch comes in 7 milligrams, 14 milligrams, 21 milligrams, and 28 milligrams. And the idea is that it produces a steady state of nicotine. So you put it on, it absorbs into your body, and you just have it. So rather than what people do when they smoke, which is you smoke, huge spike in nicotine, but then in a few hours it metabolizes off, what do? You want another cigarette. So, light it up. There we go, another spike of nicotine. And rather than going on this kind of, the nicotine comes up, and then comes down, it comes up, comes down, you just get the steady nicotine level. So you don't experience nicotine withdrawal. And the idea is if you don't experience withdrawal, that reduces your risk of relapsing and having that next cigarette. So that's the idea behind the patch. Nicotine can cause nightmares. So it's recommended to take off the patch at night. So the usual recommendation is you have it by your bedside in the morning, you put it on in the morning. If you shower in the morning, you wait till after showering and put it on. And then if you go to the gym, have some tape, right, so it stays on your skin, or you could just have a replacement patch depending on, if that's affordable. Or if you run or sort of exercise where you're going to sweat. And the adhesive can cause skin irritation. The nicotine doesn't cause skin irritation. It's not the drug in it. It's the adhesive. It's the stickiness. There are lots of different brands of nicotine patches. So just because somebody might have had skin irritation to one, if you try another brand, that might help solve the skin irritation issue because different brands use different types of adhesives. So that's one thing you can do. If somebody, if they're like, well, I got a rash, it doesn't mean you can't take nicotine patches. It means you should probably try another form of the nicotine patch to see whether or not that resolves the rash or not. If you're going to use something called combination NRT, which is what we recommend, is for patients that are willing, a patch plus something that they can use as needed, so a gum or a lozenge. That's what's recommended rather than just the patch or just the gum or just the lozenges. So the idea is you have the patches and then you have the gum or the lozenge at the bedside for early awakening, so if you wake up overnight, or in the morning, so that you have something to give yourself an immediate nicotine level while you're waiting for the patch to kick in. Patch easily comes off with sweat, as I mentioned, and the recommendation is to combine the patch with the gum or the lozenge for breakthrough cravings. That's what's recommended, and that's what's called combination NRT. That's all it is. Patch plus the gum or lozenge, right? So you're not relying on one format of delivering nicotine. You're relying on a couple different formats that people have some control over, right? So you control when you put on the patch, but you also are able to use nicotine on top of the patch for when you're feeling a tobacco craving. Make sense? Cool. Gums or lozenges comes in 2s and 4s. The replacement boxes are cheaper than the starter kits. The way that the gums or lozenges work is it's not ordinary gum. It's not gum that you just chew and enjoy yourself. The way that you use it is something called chew and park. You chew the gum until you typically taste it's a peppery taste in most versions. And then once you taste that peppery taste, you push it against your cheek. And that's how it works, is the nicotine absorbs through your cheek. It does not work. If you sit there and chew it and swallow, kind of like we do with most chewing gum, you're swallowing all the medicine. And so I had this one patient, God bless him, he got the lozenges, and the lozenges, same way, you swirl them and kind of push them against your cheek. I mean, not hard, but enough that there's contact. And he's sitting there chewing these lozenges, because he wants to get the nicotine as fast as possible. And he's swallowing it, and it's not absorbing. And I had to remind him, because I think I went through it with him initially, but I had to remind him that it doesn't work that way, right? That it works by going through your cheek, so give it some time. With the gum, once the peppery taste goes away, you chew it again to kind of re-get the nicotine activated. And you do that until the peppery taste is gone. And that's how the gum works. Lozenges, kind of same thing. And what's the difference between gum and lozenge? Well, whether you have teeth or not. It really is your preference, right? There's no big difference in the efficacy between the gums and lozenges. There is some peak effects. You get it about, between an hour and 2 hours in, you get your peak from the gum and lozenge. Nowhere near as fast as smoking. It's not the same as smoking, but you're going to get some faster nicotine than just putting on a patch. These are the gums, the lozenges, and the patches are all over the counter, so they all can be purchased without a prescription. There are inhalers and nasal sprays. They are for prescription only. There are some more adverse events with the spray, notably nasal congestion, and the inhaler is thought to mimic smoking in terms of the way that the blood level is. Neither the inhalers or nasal sprays are covered by Medi-Cal, but they can be prescribed to people with commercial insurance. So the elimination half-life of nicotine is 2 hours. It takes about 2 hours for the blood level to fall from peak to about half of where it is. It binds to what's called your central nervous system, to your brain and your spinal column, and it activates your nicotinic acetylcholine receptors. The patch plus the gum, or the patch plus the gum, or that should say lozenge, not patch. Patch plus the gum or lozenge is more effective than just single version nicotine replacement therapy. And the reason why you might want to proceed cautiously with nicotine replacement therapy is if somebody recently had a myocardial infarction, that's a heart attack. So if you just had a heart attack within 2 weeks, it's not that you can't prescribe nicotine replacement therapy, but you want to proceed cautiously to make sure it didn't worsen anybody's cardiac status. Serious underlying arrhythmias or heart rhythm abnormalities, serious or worsening chest pain on movement or exertion. Pregnancy or breastfeeding is a precaution, although I think at this point nicotine replacement therapy of these medicines is first line. For people who are pregnant or breastfeeding, the idea being that it is safer to be on nicotine that you're prescribing for smoking cessation than it is to be smoking during pregnancy. Adolescents under 18 years old, nicotine replacement therapy, not all formats are FDA approved, so you just have to be aware of which format's approved for which. And then usually nicotine replacement therapy is recommended for anywhere between 8 weeks to 6 months, depending on the smoker, right? So there's a pretty wide variety in the duration of nicotine replacement therapy. So it affects your brain, it affects your, so again, nicotine is not fully benign, right? It affects your brain, it affects your cardiovascular system, affects your gut, it affects glands like your adrenal medulla, it affects your salivary glands, it affects your peripheral nervous system. So, it binds to receptors throughout the body, but it's safer to be on nicotine and not be smoking than it is to be smoking and nicotine plus all of the carcinogens that come from smoke. This is what the blood level looks like. So when you smoke cigarettes, it's like in blue. You get a spike within 20 minutes, right? Like boom, blood level. If you look at the lighter blue, that's the nasal spray. And the nasal spray and the inhaler kind of mimic what regular smoking is. You get a spike usually within about first 20 minutes of using it. But then kind of like with regular cigarettes, right? It wears off over the course of 2 hours, I mean, at the end of an hour, you're already at, a fraction of the blood level that you were at before. But compare that to the gum, which is in yellow. The gum doesn't give you that peak effect. But at like 40 minutes, and, this is the investigator, sort of Columbia put this together. At 40 minutes, you actually get like a decent blood level of nicotine. And the patch, you put it on and kind of it slowly absorbs throughout the day, right? So you get this kind of slow increase and till you come to steady state. So although it's the same molecule, the different ways of delivering nicotine replacement therapy give you different blood effects, right? So you can see why combining the patches with the gum give you a more kind of steady state blood level for nicotine, give you a more regular blood level, particularly in the morning when you're usually having your first hit of nicotine cigarette. Does that make sense, kind of how the blood levels work? Okay. And I was asked to include a slide on nicotine metabolism, so this is a slide on nicotine metabolism. Nicotine is metabolized in the liver through something called the cytochrome P450 system that oxidizes it to a bunch of different things. One of the things is cotinine, which you'll see kind of right below the center. And then it's the aldehyde oxidase enzyme, which gets you from nicotine to cotinine. And that's the thing that stays in your urine for a while. So that you could test to see whether somebody has cotinine or not in the urine to see whether they've been smoking. I'm not going to go into the pharmacokinetics more than that. Okay. So the nicotine patch costs between $1.50 and about $4 a day. It is covered by Medi-Cal. For people that smoke about 25 or so cigarettes a day, the box says 20 milligrams every day for 4 weeks, then 14 milligrams for 2 weeks, then 7 milligrams for 2 weeks. That is like a 6-week taper. That's a pretty abbreviated taper. And for some people, they need it for longer. And particularly for people that are still smoking, I say keep them on the 21 milligram patch until they've actually are either non-smokers or have really drastically reduced their smoking such that you can justify reducing their nicotine intake. The common side effects are skin irritation and skin issues of worn at night. So that's the patch. The gum, between $2 and $6 a day. It is covered by Medi-Cal. It's 2s and 4s. So weeks 1 and 6, one piece every 1 to 2 hours. Weeks 7 to 9, one piece every 2 to 4 hours. And weeks 10 to 12, one piece every 48 hours. Classic taper. And again, this is a 3-month protocol. Some people need it for longer. And particularly people that are dealing with other psychosocial stresses. I've had patients on this for 6+ months, right? And that's okay, as long as people are making progress, as long as the risks of smoking are outweighed by the benefits of taking the medicine. The common side effects are jaw pain and mouth soreness. The lozenges, also covered by Medi-Cal, between $3 and $5 a day, available in 2s and 4s, and very similar protocol to what you see with the gum. Mouth soreness, dyspepsia, which is upset stomach, and nausea are the most common side effects. Nicotine inhaler. These are now, it's a more expensive option. It's $7.35 a day for 6 cartridges. You're allowed between 6 and 16 cartridges per day, initially one every 1 to 2 hours. Common side effects are mouth and throat irritation and cough. It is not covered by Medi-Cal, but you should know it exists. And the nasal...
How much the nicotine in that when compared to e-cigarettes?
Yeah, so e-cigarettes are much, much stronger than the nicotine inhaler. So the nicotine inhalers, if I'm remembering correctly, are somewhere around 4 milligrams. I have to look it up, but it's either like 2 or 4 milligrams. It's an inhaler. In a common cartridge in an electronic cigarette, you'll get like 20 milligrams of nicotine, or 50, right? So you're looking at anywhere between 5 to 10 times as much nicotine in an electronic cigarette as you would be receiving in a prescribed nicotine inhaler.
When you say not covered by Medi-Cal, do you just mean like you need a treatment, like a
Yeah.
card?
Yeah. So when I say not covered by Medi-Cal, let me elaborate. So so Medi-Cal will pay for it, but you have to submit something called a treatment authorization request. Within the county system, that means that it's not on our county formulary. So you can't go into Orchid and write an order for the nicotine inhaler or nasal spray. You would have to put in a non-formulary request. So it's not that you can't prescribe it, and it's not that Medi-Cal won't cover it. It means that you have to fill out what outside of Medi-Cal language we call a prior auth, a prior authorization. You have to put in a request for the insurance company to pay for it. within the public system, we call those TARs, or treatment authorization requests. And a TAR can cover both the inhaler or the spray. The idea behind I'm going to suggest that one of the reasons that Medi-Cal has it structured that way is to push people to try the patches and the gums or the lozenges first before you try the inhalers or the sprays, which are just a little bit more expensive. But if you have a patient, if you're working with a patient and they have responded to nicotine replacement therapy, but not, they haven't fully responded and they feel like they really need an inhaler or a spray, it is reasonable to go in and put in a non-formulary request if you're in the county system, or ask the pharmacist to fill out the TAR if you're outside of the county system. Does that answer your question? All right, cool. And nasal sprays, $4.12 a day. It's 1 to 2 doses, which is 2 to 4 sprays per hour. Nose and throat irritation, sneeze and cough. And you have to fill out, I shouldn't say not covered by Medi-Cal, I should say have to fill out a prior auth to get Medi-Cal coverage. Okay, so that's nicotine replacement therapy. Is everyone clear on what combination NRT is? Patch plus gum, lozenge, or plus, and then you can also add on, like you could do like the patch plus the gum or lozenge plus like the nasal spray or the inhaler. Like that is also considered under the umbrella of combination nicotine replacement therapy.
About that though, is there like a not to exceed all these together?
Yeah.
And is Medi-Cal going to pay for that all at the same time?
Yeah, so
What are they going to pay for the other?
So Medi-Cal will pay for patches plus gums or lozenges as long as those are prescribed. And I don't know, I would have to look up the actual limits, but I've gotten patients 30-day supplies of each of those, like a box of the gum and lozenges plus a pack of 30 of patches. That's routinely covered. What is it? It's like have you ever had a cough drop? It's like a cough drop. Those are lozenges. They're like a hard candy. I mean, this isn't candy. This is a medication. But that's what it's like a hard candy. That's what a lozenge is. There's a question in the back. So are you asking how much nicotine is too much? Yeah, so, right. Those are what are in the standard package inserts for those medications. Now, there are many different brands, and so they may not all follow this exact package insert, but those approximate what you'll commonly find. So, how much nicotine is too much? Well, we know that people that smoke cigarettes, each cigarette has about 1 milligram of nicotine. So, if you're smoking a pack a day, which is 20 cigarettes, then you can tolerate comfortably 20 milligrams of nicotine a day. Your body can tolerate that, right? So what I recommend is give somebody a nicotine patch that matches how much they smoke throughout the day. So 1 pack a day equals 21 milligram patch. If people, one of the nice things about it as needed, nicotine gum or lozenge, is we're not talking about that many more. It's 2 to 4 milligrams more. It's not like in the tens of. It's not. Yeah, it is kind of an awkward placement. There we go. It is in it's not in the tens of more. We're talking about single digits. And so, typically, if people are beginning to use more than their body can tolerate, they're going to have side effects. Most commonly, nausea. They're going to feel a little flush. People they don't feel good and they stop taking the additional nicotine. So what I've seen people tolerate 40 plus milligrams of nicotine a day. And if you're smoking 2 packs a day, then you can tolerate comfortably 40 milligrams of nicotine plus likely, additional nicotine on top of that because you're now more nicotine tolerant. So I tend to be very aggressive in the way that I dose nicotine. Now, is it possible that somebody might overuse nicotine and use it to the point where they become physically sick? Yes, it's possible, but then the physical symptoms they have, dominantly nausea, flushing and maybe some tremor, are going to then trigger somebody to not then continue to use. And one of the things I recommend is to titrate the amount of nicotine that you offer somebody to the amount they're smoking. So if somebody's smoking a quarter pack a day, they probably don't need more than a 7 milligram nicotine patch plus a 2 milligram gum or lozenge PRN, right, just as needed, that they can use a handful of times a day. And so you can use the amount that people are smoking and dose the nicotine replacement therapy to approximate what they're taking. Where I have seen people run into trouble is, I remember there was a guy, I was working at a hospital, and he was there for, I think, a cardiac procedure, and he was really unstable from a cardiac perspective. And I'm a psychiatrist, so why would a psychiatrist be involved in this care? So I was a psychiatrist, and I was called emergently to the bedside because he wanted to leave against medical advice before getting his cardiac procedure. He smokes 2 packs of cigarettes a day. And they gave him absolutely no nicotine replacement therapy, right? So then he was faced with, are we going to let this guy go with this unstable, literally could drop, his heart could stop, he could drop dead at any moment, so that he could go smoke, which is really just what he wanted. He just desperately wanted to go smoke. Or should we treat him with nicotine replacement therapy? And I said, treat him with nicotine replacement therapy. It should help calm him down. And so they literally cut the 7 milligram patch in half. They gave him 3.5 milligrams of nicotine. And I was like, no, 21 milligrams. And I get their concern. He's a cardiac patient. I was like, but at that point, the risk-benefit is such that the risk of him leaving, pretty high. The risk of him, when he's on telemetry, monitoring his cardiac rhythm, of being able to identify any cardiac rhythm changes that would come from nicotine, is you'd be able to find and respond to that, right? So we ended up increasing this dose to a 20 milligram patch. So I see clinicians be very tentative with nicotine. And what I suggest is this is something you can be aggressive with. You don't want to give a 1 cigarette every month smoker a 2 21 milligram nicotine patches. That's too much nicotine. But you want to titrate the patch to more or less match what they're smoking on a regular basis. And then the as-needed nicotine that they could take on top of that, they sort of take it to the point where they're craving it. And as long as they're not taking it to the point where they're making themselves physically sick from nicotine, they should be okay. Does that answer your question? Okay, cool. Bupropion goes by the trade name Zyban if you're using it for smoking, or Wellbutrin if you're using it for depression. The exact same molecule. It's also an antidepressant. It improves the probability of quit success compared to nothing overall. The studies of bupropion added to things like nicotine replacement therapy or added to Varenicline show there's some studies that show some added benefit, particularly for people with depression or with who have a lot of concerns around weight gain that bupropion can help mitigate. It is contraindicated in those with a seizure disorder. It's contraindicated with those with bulimia or anorexia that are predisposed to seizures. And it also says it's contraindicated in bipolar 1 disorder patients. That being said, you can use this in patients with bipolar disorder if they're on a good mood stabilizer. If they're otherwise psychiatrically stable, you can use bupropion if they're on a decent set of mood stabilizing meds. But for those who are bipolar without mood stabilizing meds, you generally want to stay away from Wellbutrin. The recommendation is that you dose it based on quit date. Now, I mentioned quit date. Ideally, your patients have a quit date. I will prescribe these medications to patients that don't have a quit date, right? That say, I'm thinking about smoking, I might try to cut down my smoking, but you don't necessarily have to say, okay, what's your quit date? And then I'll write you the quit. In other words, you can prescribe these meds not contingent upon there being a specific quit date, because these medicines can affect smoking behavior even if somebody is not actively ready to quit right now. So they can help people cut down, they can help people reduce. But classically, the product insert is 1 to 2 weeks before the quit date. You start 150 milligrams daily for 3 days, and then increase to 300 milligrams. What can Wellbutrin side effects? So it can cause jitters, insomnia, and classically dry mouth. It can cause a lot of dry mouth. It can be efficacious as a maintenance medication for 6 months. So there's lots of people who are on bupropion their whole lives for depression, so it can be used long term if somebody's benefiting from it. But it's clinically for smoking, people are on it anywhere between 2 to 6 months, and you can safely combine it with nicotine replacement therapy, and it can be helpful to some patients. So let's talk about the formulations, please.
My son is a smoker.
Yes.
So he started to
called me, and it's a pleasure neurotransmitter, and I said, I'm serious.
So,
Now it's just like,
all right.
how I can just like, I don't know.
So the
Like he was using it, and he was saying it was very pleasurable to smoke.
So the comment was, hey, I have a family member who took bupropion, and he said that it made my smoking feel better, made it more pleasurable. Now, with any of these medications, whether you're talking about the molecule of nicotine or bupropion or varenicline, whether it's Chantix, Zyban, or patches, gums, lozenges, inhalers, or sprays, there are always idiosyncratic effects. That means that anyone can respond in any particular way. So it's possible that your family member might actually not respond to bupropion. It's possible that this medicine may not help him quit smoking. This may not become part of his smoking cessation strategy, right? He might need a different strategy. If that's true, like I don't know exactly what it is. I mean, I'm not trying to cast doubt, but he might be smoking less even if he enjoys smoking more. I mean, that's possible, but I don't know. And it could be that he's just not responding to the medicine. And that happens with behavioral health medicines all the time. Not everyone responds to every medicine. So it has been validated compared to placebo that people smoke less when they take bupropion compared to not. But does that mean every single person in the trial smoked less? No, it doesn't. It just means that there was enough people that responded in the clinical trial to show a clinical effect. Yes.
So would we be able to use this for people that would like to quit marijuana? They have been on it for 16, I'm now 50. I would like to stop. Would this be a medication you could use? It seems like it's getting the same.
Oh, good question. So the question is, does bupropion help people that want to cut down smoking things that aren't tobacco, such as marijuana? So you can smoke a lot of things. So you can smoke things like cocaine, you can smoke things like marijuana, you can smoke a lot of things. And there's a lot of people that don't want to smoke marijuana anymore. There are no FDA-approved medications for cannabis use disorder. So I cannot sit here and tell you that there's any good FDA-approved evidence that bupropion has any effect for cannabis use disorder, and it has been tested. There are two off-label medicines that can be used off-label that have shown some promising trials, but their trials, it's not a full RCT that would meet muster for the FDA. So those two medications, I'm curious, are gabapentin and N-acetylcysteine. And there's some early evidence, I think, and don't hold me to this, I think around topiramate. But the classic ones, the trials are gabapentin and N-acetylcysteine, which is like a dietary. I mean, it's you can buy it over the counter. Right. But not everyone responds to those, and so I don't want to sit here and promote. I'm not trying to say that those are like the off-label cures for cannabis use disorder. And unfortunately, bupropion is probably not going to pan out as being like super effective for cannabis use disorder because a lot of trials have been negative. Okay, bupropion is covered by Medi-Cal. Again, the recommendation is 150 once a day and then 300 once a day for 7 to 12 weeks. The common side effects are insomnia, jitters, and dry mouth, and it works by blocking the what's called presynaptic neuron reuptake of norepinephrine, serotonin, and dopamine. So I want to, because I've been asked, so you mentioned bupropion XL. Well, that's Wellbutrin XL. But what about bupropion SR, which is what Zyban is, right? That's a different formulation. So there's actually 3 formulations of bupropion. There's an immediate release, a sustained release, and an extended release. So the XR formulation. The immediate release you have to take 3 times a day. And so, I mean, like you can see from the blood level, it lasts very briefly. So you gotta take it consistently. The sustained release formulation, which was the formulation that was tested in smoking cessation, shows that there's two peaks, right? So you take it twice a day. And the XR formulation, if you just kind of look at the duration of the blood level, is not the exact same as the sustained release, but it lasts most of the day. By hour like 18 to 20, you still have a blood level of bupropion XR, and particularly of the metabolites of bupropion XR that are thought to be responsible for some of the smoking cessation effect. So at this point, bupropion XR, we know that the blood level is high enough over duration, long enough time that you can dose it for depression at least once a day. Many of the clients and patients that I work with have trouble with twice-a-day medicine. Right? They take all their medicines at night, like everything's just at one time. But take them all in the morning. Bupropion is a medicine you want to take in the morning. because it can cause insomnia. So you take all your medicines in the morning. So I usually recommend that people prescribe the XR version because of improved adherence, because people will take it. But you can also take the SR version, which was what Zyban is. It's classically a twice-a-day medication. And so whether you're talking about 150 of SR once a day or 150 twice a day, or 150 of the XR version once a day or 300 twice a day, you're going to get a clinical response from each. And the XR version has been validated for smoking cessation, so you can use it. Okay. The parent drug, so bupropion itself, lasts the half-life is 8 to 10 hours, so it lasts altogether 16 to, say, 25 hours, but is metabolized into hydroxybupropion, thiohydrobupropion, and ethyrohydrobupropion. The hydroxybupropion is the major metabolite, and that's what's thought to exert most of the smoking cessation effect. These metabolites last much longer. Their half-life is about 24 hours, and they accumulate more than the parent drug bupropion. And they're metabolized through a liver enzyme called cytochrome P450 2B6 that converts bupropion to hydroxybupropion. Okay. So bupropion has the most precautions and contraindications. So if somebody is on Wellbutrin, you should not prescribe them Zyban because it's the same molecule, right? So you want to just be careful that you're not trying to prescribe bupropion to somebody who's on bupropion. People with liver injury, again, the bupropion is metabolized through the liver, so it's recommended to, you can use it in liver injury, but you just have to be careful about the dose. It's not recommended in people who are pregnant or breastfeeding. Its FDA approval for adolescents is for depression, but last I read, not for smoking cessation. And there was a black box warning around suicidal thinking with bupropion that ended up being removed because bupropion is not actually associated with suicidal thinking. But that said, anybody who's taking any psychiatric medicines, including antidepressants, you just wanted to monitor to make sure they're not having any adverse effects, including psychiatric effects. And you shouldn't give bupropion to people who have seizures, who are also on another type of bupropion, who are currently or had bulimia or anorexia, who are abruptly discontinuing alcohol or sedatives like benzodiazepines, because those are people at risk for seizures, who have taken something called a monoamine oxidase medication. So those are like Nardil or Parnate. Those are medications you just want to stay away from in the past 14 days for somebody to be on bupropion. Okay. Any questions about bupropion? I know this is technical, but I got feedback that people wanted more technical information, so that's why it's technical. Okay. So the last molecule, Varenicline, goes by the trade name Chantix. Chantix. This is, people ask me about Chantix. This is it. This is the deal. So Chantix is a high affinity. It binds really tightly to a part of the nicotine acetylsolic receptor called alpha-4 beta-2. The alpha-4 beta-2 subunit, but it only partially activates it. So it provides mild activation while blocking nicotine from hitting the receptor. That means that if you start Varenicline and then suddenly come off of it, you can actually experience some nicotine withdrawal, right? Because you're losing that mild activation. So it's recommended to taper people on and taper people off. It is, at least in trials, thought to be the most effective single agent. So if you had to pick one thing, this, ostensibly could be the thing. And when I talk to people about smoking cessation, I say, do you want a pill, which would be Varenicline or bupropion, or do you want things that aren't pills, patches, gums, lozenges, or, if I can get them, the nasal sprays and the inhalers, right? So, are you looking for pills or not pills? And you can combine, you can take Varenicline, and this might blow your mind, but you can use as needed gums, lozenges, nasal sprays, or inhalers on top of Varenicline. And you might say, well, wait, you just told me that Varenicline blocks nicotine receptors, so why would you use nicotine on top of that? It does, but there is thought to be, it's not it's more of a blunting than a full binding, and people can still get some symptomatic relief from as-needed nicotine on top of Varenicline. But one of the things you don't do is prescribe Varenicline with a patch, because you don't give somebody a medicine that's going to block nicotine from working and then give them a regular dose of, that doesn't make any sense. But you can use as-needed doses of nicotine replacement therapy. You start 0.5 milligram once a day for 3 days, then 0.5 milligram twice a day for 4 days, and then 1 milligram twice a day until the end, and then you just taper them off. So then you go from 1 milligram twice a day to 0.5 milligram twice a day to 0.5 milligram once a day, then off. It causes nausea, insomnia, and headache. It's between $6 and $7 a day. It is covered by Medi-Cal. I already went through the dosing. Vivid dreams are also a side effect. It lasts a long time in the system. So it takes 24 hours for the blood level to go down by half. A large percentage is just you pee it out through your kidneys. So so this is one of the few medicines that the liver doesn't make a huge impact on. It just, you take it, it lasts a while in your system, and your kidney eventually filters it out. It does not inhibit or induce the activity of most liver enzymes. So unlike nicotine, which can be a big inducer of liver enzymes, Chantix does not do that. So this is what the blood curve looks like. And this is time in hours. You can see that there's not that many what's called varenicline-related material or metabolites. You just kind of get a decent level of nicotine, varenicline, it lasts, about 60 hours after a dose. These are the metabolites. That's all I'm going to say about that. Okay. So what are the precautions? So because it's metabolized not by the liver but by the kidneys, in somebody that's got really bad kidneys, you might need to keep the dose low. It's not that you can't use it, but you just want to be more cautious with the dose. It's not recommended in people who are pregnant or breastfeeding. Just the safety hasn't been verified in those populations. It is not, to my knowledge, FDA approved for people under 18. And so people ask about a couple things. So Chantix, when it first came out, had all this press around suicidal thoughts. Chantix causes neuropsychiatric decompensation. And there are patients who have taken Chantix, and it has caused psychiatric problems. So Chantix, in some sense, can cause neuropsychiatric problems. So can placebo, right? And so can nicotine withdrawal. Like any of these things can cause psychiatric exacerbation. So the idea behind Chantix isn't that you can't use it in people with psychiatric conditions. You just wanted to make sure that people are supported and monitored. Nausea, sleep disturbance, headache, flatulence, which is farting, constipation, taste alteration, and rare neuropsychiatric symptoms are all possible with varenicline. So the FDA in 2012 said that there was a minor risk of increased rate of cardiovascular events with varenicline. The recommendation was to weigh the risks and benefits of use. Well, this is what we know about the cardiovascular risk. There was in the SING 2011 trial, varenicline was associated with increased risk of cardiovascular events, so strokes or heart attacks, in 1.06% of the participants compared to 0.82% of the participants in the placebo group. So that's not a huge difference. We're talking about a fraction of a percentage increase. In the meta-analysis by Prochaska that was published in 2012, again, you were looking at 0.63 versus 0.47 that was neither clinically or statistically significant. And in a larger trial that was out of Denmark that looked at like 17,000 or 18,000 participants, there was no association between taking varenicline and cardiovascular death. So it's thought now that varenicline, there are some early smaller studies that suggest that varenicline might have some effect on cardiovascular status, but the cardiovascular risks of smoking are so much greater than the cardiovascular risks associated with varenicline that the risk-benefit from my vantage point still supports prescribing varenicline, even if somebody's at risk for a stroke or heart attack. And what about psychiatric events? Well, again, in 2008, the FDA said increased risk of behavior change, like agitation, depression, and suicidal thoughts of behavior for both varenicline and bupropion. Now, a lot of these could have been from nicotine withdrawal, right? Because in these trials, people had stopped smoking, and these medicines were being used to treat people who had stopped smoking. And as of 2010, there were, 78 events overall that had been reported to the FDA related to psychiatric events. So there was a large trial, particularly prospective trials that were conducted to evaluate what is the neuropsychiatric risk from varenicline. And actually, these prospective trials have not shown that there seems to be a well-established increased risk of neuropsychiatric events that are attributable to varenicline and not other reasons, right? So there is populations of people that do have suicidal thoughts and agitation, but it's not at this point thought that varenicline is a major driver of those. So in 2016, the Food and Drug Administration rescinded the black box warning regarding neuropsychiatric effects. It's not that these side effects aren't present; they're still present, but that the benefits of stopping smoking outweigh the risks of these medications. So if you start somebody on bupropion or varenicline or even nicotine replacement therapy, I just ask people to communicate with me and let me know if they're having any psychiatric decompensation. And varenicline has been now well established in schizophrenia. You can check my receipts, which are on the slide. And I'll just mention, I've talked about the 3 FDA-approved molecules: nicotine, bupropion, and varenicline, which is, patches, gums, lozenges, nasal sprays, Zyban, and Chantix. You can use things off-label. I'm not going to get into these, but I'll just say clonidine and nortriptyline both have some off-label trials showing that they're not FDA approved for smoking cessation, but you can try them particularly if one of the 3 FDA approved medicines isn't doing the job. Okay, during pregnancy, nicotine replacement therapy really remains first line. There's no evidence of perinatal harms related to nicotine replacement therapy among pregnant women, and the conventional wisdom is that nicotine replacement therapy is safer than smoking. The metabolism of nicotine is increased during pregnancy. So if you were prescribing nicotine replacement therapy to a pregnant smoker, the idea is you might need to adjust the dose as people become more and more gravid. Varenicline and bupropion metabolism isn't affected by pregnancy, but there's really insufficient data to support varenicline or bupropion for smoking cessation during pregnancy. And after pregnancy, actually the use of NRT while breastfeeding is safer than smoking. So the idea is if somebody still needs nicotine replacement therapy to support they're staying quit, that it's better to give them nicotine replacement therapy and have them breastfeed than have them return to smoking. Because a lot of the smoking metabolites do come out in the breast. Bupropion and its metabolites are present in the milk of lactating women, and we don't know, or at least last I checked, about varenicline. People with mental illness oftentimes need medication at higher doses, longer duration, and in combination compared to people without mental illness. People with bipolar disorder should only be on bupropion if they are on a mood stabilizer, and each agent is effective for those with schizophrenia. So you don't have to, you don't say like, oh, if you have schizophrenia, you have to be on bupropion. You can prescribe nicotine replacement therapy, and you can prescribe varenicline too. What about people who are in alcohol and drug rehab? Quitting smoking during the first year of substance use treatment increases better alcohol and drug outcomes. So it actually helps you not drink to quit smoking. It helps you not use cocaine to quit smoking. It helps you not use meth to quit smoking. So all the evidence at this point is if you're in a substance use disorder treatment program, use that as a chance to quit smoking. Unfortunately, smoking cessation isn't paid for by specialty addiction treatment, right? Drug Medi-Cal doesn't pay for the treatment of tobacco use disorder. So the specialty addiction treatment industry implementing this can be tricky given that the payment systems aren't fully aligned around that, but that's the recommendation. And so I'll just and then I know I'm at time, but this is my recommended kind of medication strategy, which is super small and which I'm happy to distribute to you in a written format after this. But it's, if you have somebody that smokes a few cigarettes every once in a while, I say offer them some gum or lozenges in a dose that matches roughly what they use. So if people smoke 2 cigarettes at a time, offer them a 2 milligram gum or lozenge. If people smoke 3 to 5 cigarettes at a time, offer them a 4 milligram gum or lozenge. It matches roughly the amount of nicotine that they take in when they smoke. Because some people that only smoke when they go out, right? They only smoke when they're at the bar. They don't smoke on an everyday basis, but they smoke periodically. I say use an as-needed nicotine replacement therapy product to help support them. But if you're smoking 5 or more cigarettes a day, I think you've now bought yourself a patch, right? Or Varenicline, right? Or Chantix. And whether you choose the patch or Chantix really depends on your preference. Do you want to be on a pill or do you want to be on a patch? But you have to pick one. It's either the patch or Chantix. You don't do both. And then you can combine the patch or the Chantix with like a 2 milligram as needed gum or lozenge, or if needed, nasal spray or inhaler. And if somebody also wants a third medication, and let's say they have depression, or let's say that they're worried about weight gain, you can also add bupropion on top of that. And the dose of nicotine replacement therapy goes up as the amount that you usually smoke increases, but you don't adjust the doses of Varenicline. That's the standard dose for everybody, and you don't adjust the dose of Bupropion. So a half pack a day smoker gets a 14 milligram patch, and a 1 pack a day smoker gets a 21 milligram patch. So that's the kind of recommended medication strategy that matches what people are smoking, with the idea being that you want to give people options. This is the menu of options, right? It's not that people need to be on 3 different medicines. It's these are the menu of things that are available. Which of these things are you interested in? Which of the side effects you can tolerate? Which of the side effects you absolutely would want to avoid, depending on the patient? Okay. Do I recommend vaping or e-cigarettes as a tool to quit? I don't. E-cigarettes are associated with significant less quitting among smokers. That said, e-cigarettes are probably less harmful from smoking, right, than smoking. So, like, it depends on if your frame is harm reduction. If you say, I want to not, I'm not ready to do smoking cessation, but I want to reduce the harm associated with smoking, I can reasonably say that it's likely that e-cigarettes are less harmful than conventional cigarette smoking. But there is no evidence that being on an e-cigarette will then get you to quit e-cigarettes, right? Like they're not a validated strategy for quitting. I already kind of had these slides. So, okay, SmokeAware.gov, which goes to 1-800-NO-BUTS, Nicotine Anonymous, the UCSF group up Smoking Cessation Leadership. And so don't recommend light cigarettes, natural cigarettes, smokeless tobacco, snus, e-cigarettes, and be persistent. All right, thank you. Yes. Yes, absolutely.
Yeah, so that brings us to wrap. Let's have questions for Brian. One or two questions, short, and then I'll give wrap up on where you're going to get the slides afterwards.
So the question was, my friend's husband had a rash, it looks like a blistery rash on Chantix. That's not a common side effect, but anything's possible, because there are people who have allergies. So it's possible somebody might have an allergy. Oh, okay. Which that can happen with all kinds of medicine. Right. It's not like a side effect, it's an allergy.
If a person had depression, person diagnosed with depression and smoked cigarettes, and you prescribe the Bupropion, will it treat the depression and they still be the NRT, you think?
So what I would say is, if I had somebody with depression and tobacco use disorder, right,
yes,
depressed smoker,
yes,
I could try Bupropion, and if they were up for it, I would probably also add nicotine replacement therapy, because the combination of nicotine replacement therapy, and I mean combination nicotine replacement therapy, patches plus gums or lozenges, alongside Wellbutrin, I think is going to be more effective than just Wellbutrin alone, right? But if he says, I don't want that stuff, you can still see some people smoke less due to Wellbutrin alone, even without nicotine replacement therapy. So I would offer combination nicotine replacement therapy, but I would still prescribe the Wellbutrin and see if it had an effect on the smoking. Does that make sense? All right, cool. Hey, thank you so much.
Great, everybody. So, wrap up things. Making your evaluations at the registration desk at Cynthia, get your CD credit. The slides I'm going to post on the Charles University Drug Addiction Research website.
You'll distribute the link.
I'll distribute the link. I should be able to tell everybody. And we'll put the slides, the talks, and the schedule there. The next event is July 12th, it's Healthy Endowment. More geared for community engagement, but I think everybody here would have a great time and always organizing it. And if you have any sort of comments for next year, or things you like or didn't like, you would tell me, or Brian, or Cynthia, or us. But we'll see you next year. Thanks everybody for attending. Thank you.
Okay. Yeah, what's up?
it would be kind of like, the way I think about it is I would say, here's three things. I want all of them. I want to take everything. All of them. No, but like, but that's what I mean. And I would say, like, there is no harm, like, seeing if anyone being prescribed pharmacotherapy. Like, so it's not like but there are some, I know that you take, like, you can do it, like, and it's tolerable, like, these medicines are not for each other. So it's like, one thing people are doing is treat depression and then help with the behavior. If I really want that, then I'll offer it.
Are you ready to stop smoking?
Yeah. Can I answer your question about CBD? Great.
Okay. Okay. Thank you. Thank you. You enjoyed it?
Yes,
I think you need that a lot out of it. Yeah. This is theirs. This is mine.
Okay, great question. So,
All right, let me get out of here. I'm in a place where I gotta go practice my part.
there's a philosophy that in order to treat alcoholism, you have to get somebody to stop the
Do you need any help? I think not. I think everybody. No, I think they're all going to take. They're going to take Lyft or Uber.
Okay.
Brian's going to take this.
and
Right.
Okay.
Thank you so much. You liked it?
Yeah, it was really great. Everybody
or co-occurring depression with, so one of the
talk again on Tuesday.
Okay.